Chapter 23, Care of Patients with Brain Disorders. Lesson 23.1, Care of Patients with Brain Disorders, Theory Objectives. Choose the appropriate nursing actions and observations to be carried out for a patient experiencing a seizure. Explain why seizure may be a consequence of a stroke, tumor, or infection in the brain. Compare the subjective and objective findings of thrombotic stroke and intercerebral bleed. Devise a nursing care plan for the patient who has had a cerebral vascular accident, a CVA, a stroke, TIA. Write nursing actions to assist the patient who has developed a complication after a CVA. Summarize subjective and objective findings indicative of a brain tumor. Illustrate the pathophysiology behind the symptoms of a brain tumor. Discuss the mechanism by which infection in the brain may cause increased intracranial pressure. Compare and contrast the symptoms of meningitis and encephalitis. Distinguish the assessment data that differentiate migraine headaches from cluster headaches. And compare the signs, symptoms, and treatment of trigeminal neuralgia and Bell's palsy. Clinical practice objectives. Identify appropriate transmission-based precautions to be used with meningitis caused by bacteria and viruses. Teach a teenage patient recently diagnosed with epilepsy what she needs to know about her disorder and care. Perform neurological checks on a patient who is admitted with a suspected CVA. Assist with the care of a patient who has had intracranial surgery. Devise a teaching plan for the patient who has had a CVA and has right-sided hemiplegia. So seizures, disorders, in epilepsy. The patho of a seizure disorder. It's a chronic disturbance of the nervous system characterized by various types of persistent seizures that are the result of abnormal electrical activity in the brain. So we break it down into two types of seizures. We have focal or partial seizures. These are going to be in one part of the brain. They're going to be localized signs or symptoms. We'll be able to say, hey, that's because they're having a seizure in this lobe or in this area. Whereas generalized seizures are on both sides of the brain and the whole body exhibits the signs and symptoms. Focal seizures. Simple focal seizures are abnormal, localized cortical discharge without loss of consciousness. May cause an emotional reaction or change the way that things look, smell, feel, taste, or sound. Also, they may cause involuntary jerking of a body part like an arm or leg. These simple focal seizures may cause spontaneous sensory symptoms like tingling, dizziness, or flashing lights. Complex partial seizures and automatisms. Yep, that's the word. I'm gonna let you guys work on that one. AKA, these are seizures in the temporal lobe. They involve a level of consciousness changes, either a total loss of consciousness or decreased awareness. They may cause staring, unresponsiveness to environmental stimuli, or repeated movements like hand rubbing, chewing, swallowing, or walking in circles. Partial seizures can become generalized. Generalized seizures are bilateral, synchronous, electrical discharges in the brain that affect the whole brain with no warning or aura. For example, absence seizures, myoclonic seizures, clonic seizures, tonic seizures, tonic-clonic seizures, atonic seizures, and infantile spasms. I will tell you that tonic-clonic seizures do often get an aura, so I don't know why our PowerPoint has that here, so just be aware of that. What are absence seizures? So absence seizures are the seizures where they may only last a few seconds. There's usually no aura or warning, no post-ictal symptoms. They come on very quickly. This type usually affect children that are between 5 and 12 years of age, and they disappear around puberty. Sometimes you might see twitching around the mouth, around the eyes. The person will either be standing and remain standing or sitting and remain sitting, and they will have what appears to be no more than just a quick lapse of attention. So they're just zoned out for a second. So then we talk about these tonic seizures. Let's jump down to the tonic seizures. With tonic seizures, there's a continued contraction of all the muscles, and the body becomes really stiff and rigid, right? This is where we might see the arch, the eyes rolling back in the head. Um, it's very, it's very different looking. Tonic clonic is where we're going to see both contraction and relaxation. So these people are going to be jerking, right? Bilateral jerking of the extremities with a loss of consciousness in both tonic and clonic convulsions. The patient may even be incontinent during the seizure, and we have to worry about them biting their tongue. We're not going to do anything, but it might happen. In the postictal phase, that's the phase after a seizure, the person will be very confused and drowsy. So they won't have a postictal phase if they have an absent seizure, but during a tonic-clonic, they will have a postictal phase. Excuse me. Okay. So myoclonic seizure, going back, these are brief shock-like jerks of a muscle or group of muscles. It's going to happen with a variety of epilepsy syndromes, and the person's usually awake, able to think clearly, but they have like a muscular jerk, right? A rapidly alternating contraction and relaxation or jerking or twitching of a muscle. These only last a second or two, and there can be just one quick jerk, or sometimes there will be a few jerks in a row within a short period of time. Clonic seizures are going to be seizures that they are basically fibrillating. They're going to be shaking, 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 shaking. Um, Huge increase of shaking from the tonic-clonic. It's not just a seizure because they're not like a tonic-clonic seizure where they're having contractions and relaxations. This is just constantly moving, right? Atonic seizures is going to be a total loss of tone. So these patients are going to probably nod off their head, get weak in the knees. They may fall down entirely if they're standing or in a chair. They may fall out of the chair, right? These atonic seizures, they lose all muscular tone. Now, during an atonic seizure, the patient is usually awake or conscious. And so we have to remember that. They know what's going on. Their body is just like completely giving up, right? So with infantile spasms, this can refer to either pallid breath holding spells or cyanotic breath holding spells where the babies are throw temper tantrums and then they have a seizure from anoxia or a febrile seizure. That's where we see the most of the infantile spasms as the temperature gets too high on the baby, usually 103, 104, 105. And once we're that high, the baby starts to seize. So we actually fix these by reducing the baby's temperature. Status epilepticus. This is prolonged partial or generalized seizure without recovery between attacks. Rapid, unrelenting series of convulsive seizures without intervening periods of consciousness and an absence of respirations. Ugh. Irreversible brain damage can occur if the seizures are not controlled. So we definitely want to get some medication on board, right? We definitely want to get them some kind of sedative to reduce the seizure action. We definitely want to get them some fluids going. We definitely want to get them some imaging to figure out what's going on. However, our priority with status epilepticus or these recurrent seizures is to keep the patient safe. We want to pad the bed rails. We want to get them to a safe place to have the seizure. Even though there's a lot of crazy stuff going on inside of their body, we must remember that keeping the patient safe is number one with these recurrent seizures. How do we treat status epilepticus? Well, we support their vital signs, right? We give them any kind of medications necessary to keep their heart beating, to keep their blood pressure elevated, to reduce their temperature. We prevent injury. That's the big one, remember? We may even have to intubate and provide respiratory support for these patients. The diagnosis of epilepsy, how do we get there? Well, first we have to do a history and physical, figure out what's going on with this patient, how long it's been going on. Then we do an exam of the specific signs and symptoms of this patient. We may also run some tests. The most common one for epilepsy is going to be your EEG or your electroencephalography with the little sticky nodes all over the head. Also, we might do an MRI or magnetic resonance imaging. We also might draw some labs to look at electrolytes to see if there's any kind of imbalance that might result in some kind of neuromuscular delay or overstimulation. Treatment of epilepsy, we want to control or eliminate the cause of epilepsy. We can put them on epileptic drugs. So big ones are going to be like phenytoin and diazepam and phenobarbital, right? So all of those medications and many more can help to control drugs. We hear about Keppra a lot. That's a big one. Patient teaching. Make sure the patient knows, especially if they're younger, they can't swim by themselves. That's so dangerous. They can't, probably should not be riding bikes or driving a car by themselves until they know how their seizure medication is going to affect them and if it's going to be well controlled on the medication. Also, we don't want these people uh, to be doing any kind of risky jobs or occupations. So if they're running heavy machinery, they don't need to do that until after they know that their epilepsy is well controlled. We also want to talk to these people about eating a ketogenic diet. Keto diets have been shown to improve the symptoms of epilepsy and the incidence of seizures. We may do some biofeedback with them. And then surgery would be if there was like a focal seizure, there was an area in the brain we could pinpoint as the area for epilepsy, we could go in and remove that portion of the brain to reduce the epileptic symptoms. So during a seizure, what do you need to know? Well, you need to report the time the seizure began, the time it ended, what the patient was doing, what triggered it, right? Where in the body the seizure started, what body parts were involved, which way were the eyes moving? Did they constrict? Did they dilate? Did they deviate? Did they roll? What side of the head, or what side of the body did the head turn towards? Did the patient cry or scream when the seizure started? Is there evidence of repeated movements like lip smacking, chewing, grimacing, tapping, or pill rolling? Whether the movements were bilateral and symmetrical or unilateral and asymmetrical. If there was incontinence, this is a big one. So any incontinence, vomiting, frothing, or bleeding must be reported to the doctor. So not just do we need to know that and observe that and document it, but it also has to be reported to the doctor. And whether the patient becomes apneic or cyanotic and has any changes in skin color or profuse perspiration. We want to tell the doctor how long the seizure was, right? What kind of movements there were. Was it a tonic seizure? Was it tonic-clonic movements? And if the patient had incontinence, vomiting, frothing, or bleeding. Very important things to tell the doctor. Post-ictal assessment. So during that phase of the grogginess, waking up after the seizure, and after we make sure that the airway is good, we will need to document the length of time before the patient was aware. Document that the patient was lethargic or confused, the patient had a headache, the patient had some kind of speech impairment or muscle soreness, and if there was an aura before the seizure started. Was there a way for the patient to know that it was coming on? And then we also need to monitor and document the effects of the seizure on the patient's vital signs. TIA, so this is not a seizure. We are going from seizure into stroke or into cerebral vascular accident. Very different. Yes, a stroke can cause a seizure. Yes, a brain tumor can cause a seizure. Yes, all of those things can cause a seizure, but seizures do not cause strokes in most cases. So TIAs are warning strokes, right? They're the little ones that happen before the big ones. There's going to be a brief interruption in blood flow. It's going to tell you that there might be something more serious coming down the pike, right? The symptoms generally last no more than an hour and they completely resolve. There's no residual deficit from a TIA. What are we going to want to do? We're going to want to do a thorough history on this patient, figure out what this patient's medical situation looks like, what their medical history looks like, do a physical exam. Okay. Oh, I jumped, didn't I? Okay. Diagnosis and treatment. We'll do a carotid ultrasound. We'll see if the carotid arteries are blocked, right? Or if there's atherosclerosis in them, if they're narrowed. We'll do blood tests. We'll do an MRI. We'll do an EEG. Angioplasty may occur. We may end up putting a stent in or going into the carotids and cutting out the cholesterol or breaking up the cholesterol, the plaque that's built inside of those carotid arteries, right? We also are going to have them change their diet. They need to eat low fat, low cholesterol foods, right? So that they don't continue aggregating cholesterol. Also, we need to tell them that they need to start exercising a little bit, moving their body. That's important. And that medications may be prescribed to prevent platelet aggregation and also to reduce cholesterol. So these people are probably going to be put on a blood thinner and a statin. CVA. So these are your strokes or your brain attacks. These are bigger than the TIA. The leading cause of disability and the fifth leading cause of death is stroke or cerebrovascular accident. There are modifiable and non-modifiable risk factors. Modifiable, your weight, your blood glucose, your level of activity, your diet, right? All of those things you can change. You can even change your cholesterol levels, right? Because what you eat is going to determine your triglycerides, etc. Non-modifiable. If you're older, that's a risk factor. If you are of a certain ethnicity, that might be a risk factor. Those are not modifiable. There's no way to change how old you are or what ethnicity you are. Pathophysiology. There may be a cerebral thrombosis or a clot in the brain, right? So this isn't just ischemic stroke. Ischemic stroke, um, that is ischemic stroke, but this isn't just ischemic stroke caused by cholesterol, right? That's one of them. You can have narrowing or the closure of a artery, or you could have a clot. If you've thrown a clot into one of those arteries, you will cause death by ischemia to everything that comes after that blockage. An embolus, a fatty embolus, a fluid embolus, an air embolus. Let's see what else there might be. Um, amniotic, that's amniotic fluid embolus. So anyway, or just, something else that's traveling through the circulatory system and gets caught in a artery and causes death to the tissue afterwards due to ischemia. Intracerebral hemorrhage. So these people are bleeding, right, inside of their brain. This can be caused by high blood pressure, increased cranial pressure. What else? All kinds of things can cause a brain bleed, right? A fall and an injury, blunt force trauma, right? Pressure on a blood vessel may also cause a cerebrovascular accident. Here's a really good picture of the major arteries supplying blood to the brain. You have the internal and external carotids, right? You have the common carotid, which is lower. And then coming off of the aortic arch, you have the left subclavian artery, that common carotid, and the right subclavian, right? And then once we get into the brain, we've got things like the vertebral artery feeding the brain, the posterior carotid, posterior communicating, middle cerebral, anterior cerebral, and anterior communicating artery, where we have those smaller branches off of those larger stems. Dangers of cocaine or meth use. People need to know that cocaine and meth are the highest risk factor for stroke. If you're doing coke, if you're smoking, those are going to put you at a high risk for stroke, more than your diet, more than your history, etc. Both of these drugs cause vasoconstriction and brain ischemia because of the constriction, right? Blood's not getting through to those tissues and they're dying. They're not getting oxygen. Cocaine also can cause hemorrhage. So not only does it cause vasoconstriction and ischemia, but hemorrhage. So you're at greater risk for ischemic stroke and greater risk for hemorrhagic stroke. Using these drugs causes a 5-fold increase in the incidence of stroke. And the incidence of this type of stroke has greatly increased in young adults. Cerebral aneurysm and AV malformation or arteriovenous malformation. This is an abnormal ballooning of an artery wall. And AVM is a congenital abnormality that is a tangled mass of malformed thin-walled dilated vessels that form an abnormal communication between the arterial and venous systems. And a cerebral aneurysm is that outpouching, right? The ballooning. And either one of these can bust, right? Or become compromised in some way that we have a massive hemorrhage. Here's a good picture of a dissected circle of Willis that shows a large cerebral aneurysm. See it bled out. It's enormous. Warning signs of stroke. The big thing is the acronym FAST: facial drooping, arm numbness, speech difficulty, and time. When did it happen? How long? What was their last known well? And you need to call someone fast, right? Teach people to seek immediate medical attention in an emergency department if any of the following warning signs of stroke appear, like sudden weakness, numbness, tingling, or loss of feeling in the face, arm, or leg, sudden trouble seeing in one or both eyes, sudden confusion. slurred speech, trouble talking, difficulty understanding what other people are saying, a sudden severe headache for no known reason, sudden trouble walking, dizziness, or a feeling of spinning around, a loss of balance, a loss of coordination, or a blackout. Huge, huge, huge that we get these people to treatment immediately. So stroke signs and symptoms are going to depend on the location of the clot or bleed. You may see major issues if you have it further down, if there's a clot further down the arterial branching, right? Because you're going to have many affected areas. Now, if it's moved in closer to one focal area, we may only see some focal deficits or some isolated issues like a right-sided weakness or a left-sided weakness or facial drooping or language issues. They may have motor function deficits. They may be weak. They may not be able to walk. They may not be able to move like they had before. Language disorders. They may not be able to speak at all. They may not be able to speak well. They may have aphasia. Aphasia is going to be no speaking or very minimal speaking. They may have dysphasia, which is difficulty speaking. They may have emotional responses that are inappropriate. They may have memory and judgment issues. They may have spatial or perceptual deficits. So, like looking at a collection of objects, not being able to name the object, that's going to be agnosia, right? Bladder and bowel incontinence may occur as well. Each area of the brain will control a particular activity. So the frontal lobe is going to be big for speech. It's also going to be really big for certain activities, like motor activities, right? Motor activities are also going to run right down the middle and then in the parietal lobe as well. Sensory discrimination, eyes being able to go to the opposite side, body awareness, writing is all going to be the parietal lobe, right? And then you can see there leg, hip, trunk, arm, hand, neck, face. Depending on where is affected, your motor activities or your may be affected as well. The temporal lobe is going to be responsible for hearing, smell, and taste, short-term memory, and reading. And then the occipital lobe is going to be responsible for visual reception. How do we diagnose this? We do an MRI or cerebral angiogram. We get these patients in for quick CT to figure out what kind of stroke it is. We can do an EEG, a brain scan. We can do Doppler flow studies to find out if we're even getting perfusion to the brain. Carotid Doppler, for example, is one. We can test for levels of glutamate in the blood. And we can also do a lumbar puncture. What are we going to do? Maintain an open airway, give them fluids, give them antihypertensives to bring their blood pressure down. Control their temperature because that may definitely be affected by a stroke. We can give them that TPA, right? That's clot buster, alteplase. And what is that going to do? It's going to break it up. You have to give it within 3 hours of the onset of symptoms. However, there is a time limit, a window, or systemic tissue plasminogen activator and other medications, right? Surgical procedures, they can go in and actually get the clot out. Pick it, go use a little device to remove the clot, thrombectomy. Complications of stroke. It gets worse, especially if it's a brain bleed, right? The hemorrhage extends or it begins to bleed again. The patient could have a seizure because of the stroke, or the patient may accumulate excess fluid on the brain, a condition called hydrocephalus. How are we going to manage stroke? Well, there's 3 primary phases: the initial care, the rehabilitation, and the continuity. Phase 1 or the initial care is going to be to maintain an airway, establish baseline data regarding their vital signs, level of consciousness, neuromuscular function, and neurological status. We might use an NIH stroke scale or a Glasgow coma scale to assess their neurological status at this time. Preserve joint and muscle function for them, prevent complications that may interfere with rehab. Rehabilitation, what do? We plan for it, and it should be started from the moment that the patient is admitted, right? Because we want to regain every deficit that every loss that we have acquired. Various members of the healthcare team will collaborate with the patient and family to help resolve psychosocial and physical problems. Patients who have had strokes can be prone to rapid mood swings and spontaneous weeping, so they need lots of great psychosocial support. And then here's a comparison of some deficits. Left-sided brain damage, we're going to see slow and cautious behavior, speech problems, aphasia, difficulty in following verbal commands, apraxia, difficulty in performing simple tasks. It'll be a right-sided hemiplegia as well. So remember, left brain damage, right side
issues. Right side brain damage, we might see quick and impulsive behavior, short attention span, left side neglect, easy distraction. Remember, right side brain damage, left side hemiplegia. Phase 3, or your continuity of care, will be discharging the patient, referring them out for rehab, and PT and OT, all that fun stuff, even speech therapy as well if necessary. And they may also be given a visiting nurse. Brain tumor. Well, it may actually start in the brain, like a primary brain tumor, or it may begin in the meninges, the cranial nerves, the pituitary gland, and make its way into the brain, right? It depends on the location and how quickly it grows. So if you have a slow growing brain tumor, you may not be as likely to have the symptoms right away, like headache or light sensitivity or vision issues. Um, but if you have a highly malignant, fast growing type, you may have those signs and symptoms appear very suddenly. We can cut out the brain tumor, right? Brain surgery. We can use radiation targeted at that particular tissue. And we can also give these patients chemotherapy. What are we going to do? Routine neuroassessments, right? Including ADLs, to make sure they're able to do everything. We haven't had any change in their baseline level of activity. Also, pain assessment and control. With brain tumors, pain is going to be a huge thing because these people are going to have increasing intracranial pressure. So it's so important that we manage their pain. That's going to be our priority. Complications of brain tumors, the accumulation of fluid inside of the skull or hydrocephalus, and also intracerebral hemorrhage or bleed. Bacterial meningitis. Bacterial meningitis is the inflammation of the membranes that cover the brain and the spinal cord, and it's caused by an infectious agent or bacteria. We do vaccinate against meningococcal, right? So meningitis immunizations are available. We also have a meningitis vaccine for adolescents now, so not just the meningococcal. Sudden onset of fever and a severe and persistent headache that is greatly aggravated by moving the head with nuchal rigidity are going to be a big thing. So neck stiffness, right? Headache, right? And then we have the Brudzinski sign and then the Koenig sign. So the Brudzinski sign of meningitis is going to be the stiffness, right? So we're going to lift the head up. And when we lift the head up, severe neck stiffness will cause the patient's hips and knees to flex when we flex the neck, right? And that'll be a positive Brudzinski sign. And then the Koenig sign is going to be also kind of related to stiffness. We're going to have the person lie flat on their back, and we're going to flex the thigh so that it's at a right angle to the trunk and completely extend the leg at the knee joint, okay? And if that is, it can't be completely extended, like their leg absolutely cannot, that is going to be the Koenig sign. And we're going to call that a positive Koenig sign if you cannot completely extend the leg at the joint. Treatment. We're going to give these people antibiotics, right? For the bacterial meningitis because it's bacterial. Also steroids like dexamethasone, anticonvulsive drugs because meningitis can cause seizures, and pain meds. Viral meningitis. Viral meningitis is going to be the most common viruses. Viral meningitis is going to be the virus version of meningitis, right? Is there anything we can do for it? Not really. We just manage the symptoms. We can't give them antibiotics. Why? Viruses aren't susceptible to antibiotics. The most common viruses for viral meningitis are going to be your enteroviruses, arboviruses, HIV, and herpes simplex. Also, with babies, we've got group strep, right? Group beta strep. It's a bacteria. Oh, excuse me, that's a bacterial meningitis. I'm off topic. I'm off script today, guys. So viral meningitis, they're going to have headache, fever, photophobia, or light sensitivity, and a stiff neck. And those are going to be your cardinal or hallmark signs of viral meningitis. We may look at their cerebrospinal fluid, like a lumbar puncture, to see what's going on, make sure there isn't a bacteria in there. It is going to be self-limiting and managed symptomatically. 7 to 10 days at home. These people are usually pretty good. They do well. Conserve the strength of the patient when they have viral meningitis, prevent seizures, and promote healing for them. Encephalitis. So while meningitis is the inflammation of the meninges, right? Encephalitis is actually going to be an acute inflammation of the brain. It is serious, and sometimes it can be fatal, right? We can get encephalitis from mosquito and tick-borne pathogens. Signs and symptoms will be stiff neck, photophobia, lethargy. Those are going to be the classic signs of encephalitis. So it's very similar to the meningitis there. Seizures, acute confusion, and flaccid paralysis may also occur with encephalitis. So we're going to basically just treat the symptoms again with general supportive measures. Other brain disorders may include brain abscesses, headaches, migraines, and it's important that when we have migraines that we find foods that are going to help, um, find foods that are going to trigger the migraine so that we can eliminate them to help um, reduce the frequency of the migraines, right? So a migraine headache. What is a migraine? A migraine, you're going to have the nausea, potentially pain behind an ear or an eye, pain in the temples. You may see spots or flashing lights. You may be sensitive to light or sound, have a temporary vision loss, and may even vomit, right? Horrible, horrible, horrible stuff. Um, Headaches are going to be mostly in the forehead and the scalp, right? And you won't have the nausea, the dizziness, the flashing lights, or the blind spots. Triggers to migraines can include emotional anxiety, contraceptives, alcohol, hormone changes, menopause, and then headaches. Anything can really cause a headache. So just be on the lookout for it. What can we do to treat headaches? Acetaminophen, aspirin, ibuprofen. We may also apply heat, right, or a cool cloth. Massages, meditation, stretching out the neck, doing relaxation. Um, Also, if we have migraine headaches, some of the trigger foods may be things that have like caffeine or alcohol, right? So if we remove those from the diet, we're going to reduce the frequency of the migraine headaches. Taking prescription medications like antidepressants, blood pressure meds, anti-epileptic medications may cause migraines or may trigger the migraines. And it's important that we reduce stress, right? We also might prescribe anti-nausea medications for headaches, to specifically migraines, to reduce the incidence of vomiting with the headaches. Trigeminal neuralgia. It is a relatively rare facial pain syndrome related to pressure on the nerve root. This is absolutely tremendous, terrible pain in the face, right? We can give the medications like carbamazepine or Tegretol, oxcarbamaz, mm, oxcarbaz, oxcarbazepine. Yep, I'm gonna do that. Oxteller, right? Baclofen, gabapentin, pregabalin, or Lyrica. These are all going to treat nerve pain. Bell's palsy. It's edema and ischemia of the facial nerve. Sometimes it can be caused by herpes simplex. Sometimes it can be caused by stress, exposure to cold, or being pregnant. Pregnancy is actually a risk factor for Bell's palsy. Numbness and partial or total paralysis of the facial muscles may occur. You may see a droop on one side of the face. Most people think they're having a stroke. It's actually Bell's palsy. It may affect speech because of the drooping. Patch over the affected eye and artificial tears, steroids, and acyclovir are going to help treat the Bell's palsy. And that is all. If you have any questions about Chapter 23 content, get in touch.